Hello, my name is Shane Shapira, and I'm a respirologist at the Toronto General Hospital. And I also run the interstitial lung disease program at the Toronto General Hospital and at U of T. And today I'm going to be giving you a primer lecture on restrictive lung diseases. This lecture is meant to be the background before our in-person lecture in class. So here are my disclosures. I have worked with several companies providing consultation services, being parts of advisory boards, and working on guideline creation. Having said that, all of the slides that I'm giving you today will use generic names of medications to mitigate any potential bias. And I want to be clear that every recommendation I'm saying today is based on international published guidelines for treatments of interstitial lung disease and pulmonary fibrosis. So here are our learning objectives. So this lecture, along with the corresponding in-class lecture this week, will meet the following end-of-week learning objectives. First, we will differentiate a parenchymal lung disease versus an extraparenchymal lung restriction. Second, we'll demonstrate knowledge of the important presenting signs and symptoms of interstitial lung disease. Third, we will list the relevant information to elicit on history when seeing a patient with an ILD. We will recognize that the initial workup of an ILD should include a search for a culprit exposure or an underlying connective tissue disease. And lastly, we'll recognize the illness that's characterized by reduced lung volumes and use that to explain how reductions in lung volumes lead to dyspnea. By the end of this module, you should be able to understand the physiology of restrictive lung disease and how that relates to pulmonary function testing. You'll learn to appreciate testing methods to assess restrictive lung disease, so pulmonary function testing and chest x-rays. We'll generate an appropriate history and physical exam for a patient who presents with restrictive lung diseases. So what is a restrictive lung disease? So restrictive lung disease refers to any condition that reduces the size of the lungs. And we define that as someone who has a total lung capacity, or TLC, of less than 80% predicted on pulmonary function testing. When we see those patients, there are several possible causes to their small lung volumes. One possible cause is that they have an interstitial lung disease, which we call parenchymal lung restriction, because the lung parenchyma is what's causing their small lung volumes. The other possible causes include chest wall restriction and neuromuscular disease, and these are called extraparenchymal causes of lung restriction, because both chest wall restriction and neuromuscular disease make the lung volume smaller because it's being squeezed from the outside rather than a problem with the lung tissue itself. In restrictive lung diseases, as I mentioned, the total lung capacity goes down. So as you look at this graph, which illustrates what happens during a spirogram or a spirometric maneuver, you can see the patient breathes all the way in and breathe to TLC, breathes all the way out to RV. And we use these tests to measure the TLC. So if the TLC goes down, other measures, like the vital capacity, or when we're measuring it on spirometry, the forced vital capacity, will go down with the TLC. This is important because we use FVC as a more convenient measure of lung restriction. So we've talked about that patients with restrictive lung disease will have a low TLC. But now we've talked about how their vital capacity will also go down. But whereas in obstructive lung diseases, patients will have a disproportionate reduction in their FEV1 and FVC, leading to obstruction. In restrictive diseases, like the ones I'm talking about today, patients should have what's called a proportional reduction in FEV1 and FVC. And what that means is that both their FEV1 and their FVC will both go down, but should go down by a similar amount so that the FEV1 to FVC ratio is normal. And by normal, I mean that ratio is greater than 0.7 or 70%. So just looking at spirometry and the spirograms, on the left, you see a normal spirogram where a patient has this triangular shape to their spirogram pattern. In the middle, you see the spirogram of someone who has obstructive lung disease, where you see this curvilinear or scooped pattern of their flows. In restrictive lung diseases, the diseases we're talking about today, what you'll see is that the spirogram has two features. It tends to be narrow and tall, and almost looks like a semicircle rather than the triangular shapes that you would typically see in a normal patient or an obstructed patient. So as I mentioned, there are several possible causes of restrictive lung diseases. Interstitial lung diseases or parenchymal lung diseases are the most important and most significant of these conditions. And one of the ways that we will help to differentiate these patients is that we see that they have abnormal imaging because their lungs are abnormal. When we look at their chest x-ray, we can see a combination of reticulation or lines and nodularity, that's dots. And so some patients may have just reticulation, some may have just nodules, or some might have a combination which we call a reticulonodular pattern. It's really important to look at the x-ray not just to see if there is interstitial changes, these lines and dots, but also to see the pattern of the lines and dots. On the left, you see a chest x-ray of someone who has upper lobe changes of interstitial lung disease. And on the right, you see an x-ray of someone who has lower lobe changes of interstitial lung disease. When we do our in-person lecture, we will have a much more in-depth discussion about how we use this to help whittle down the differential diagnosis, because upper lobe disease has a very different differential diagnosis than lower lobe disease. When we have patients with parenchymal lung restriction, we look very closely at the diffusion capacity. So once you've looked at the spirogram, then you've looked at the lung volumes, and you've established that this patient has restriction, the next step is to look at the diffusion capacity. And you may remember from other lectures and other readings that the diffusion of a gas from the lungs, and the diffusion of a gas anywhere for that matter, responds to things called Fick's law. And Fick's law tells us that diffusion of a gas is influenced by the surface area across which diffusion can occur, the gradient of the gas across the membrane, the solubility of the gas as it's diffusing, the thickness of the membrane that the gas must cross, and the molecular weight of the gas. In particular, now I want to highlight that the thickness of the membrane of the gas is really important. And if you look at the pictures on the right, on the top you see normal lung. Here you can see alveolar walls that are nice and thin. Gas can cross those very easily. On the picture on the bottom, you see someone who has interstitial lung disease, and you see that all of those alveolar walls are thickened, and that makes it more difficult for oxygen to cross that membrane. As a result, interstitial lung disease have a thickened membrane with a low diffusion capacity on pulmonary function testing. Now let's contrast that to the other two types of lung restriction, chest wall restriction and neuromuscular disease. In these conditions, the lungs themselves are normal, but the lung is being squished from the outside for some reason. This leads to what we call extraparenchymal lung restriction. In chest wall restriction, patients will have this extraparenchymal lung restriction picture. Again, that means that the restriction is caused by something outside of the lung parenchyma. You'll still see low lung volumes, so the total lung capacity will be reduced. You'll still see a proportional reduction in FEV1 and FVC. So both FEV1 and FVC will be low, but the ratio will still be greater than 70%. However, in extraparenchymal lung restriction, like chest wall restriction, the diffusion capacity is normal because gas exchange at the level of the alveolus is normal. There's no thickening of the membranes. The lung tissue itself is normal. It's just that the lung is being squished by something like a kyphosis or a scoliosis, or perhaps by obesity and just extra weight on the chest wall. In these patients, the diffusion capacity is normal. In patients with neuromuscular disease, these are patients where there's a problem with the muscles of breathing. For example, if you have diaphragmatic paralysis. They can also have extraparenchymal restriction. And the pattern is very similar to chest wall restriction. They will have low lung volumes, a low TLC, a proportional reduction in FEV1 and FVC with a ratio of greater than 0.7. They will also have a normal diffusion capacity, just like in the chest wall restriction patients. But these patients have weakness in their respiratory muscles, and we can do testing specifically to look at respiratory muscle strength. We're going to talk more about this in the lecture, but in particular, the tests we can do are things like MIPS and MEPS. MIPS stands for maximum inspiratory pressures, and MEPS stands for maximum expiratory pressures. And these allow us to do tests to check the muscle strength. We also do positional vital capacity maneuvers, where patients will do their forced vital capacity both sitting and then lying down, and we see changes based on respiratory muscle strength. So now we've talked a bit about the pulmonary function test findings in interstitial lung disease, both parenchymal lung restriction, chest wall restriction, and neuromuscular disease. Next, we're going to talk about how to take a history. Now, in the lecture, we'll talk all about the differential diagnosis, and that helps us to develop our history. But when we're taking a history for patients with these diseases, we go through these categories that I've listed here. Of course, you would ask every patient if they have respiratory symptoms, so dyspnea, cough, sputum production, wheezing, and hemoptysis. But then we start to get down into the possible causes of interstitial disease. So for example, connective tissue diseases can cause interstitial lung disease. So diseases like rheumatoid arthritis, scleroderma, and others. So we need to ask questions that are outside of the lungs, but might be related to connective tissue disease. So we asked about something called Raynaud's phenomenon, which is changes in the hands. We ask if they have arthritis or arthralgias in the joints, muscle weaknesses. We ask about skin rashes, and other findings that would suggest an underlying connective tissue disease or rheumatologic condition. We also ask about exposures because we know that some drugs and environmental exposures can cause interstitial lung diseases. So we ask about toxins like drug exposures and cancer treatments because radiation and chemotherapy also cause interstitial diseases. When we're talking about drugs, it's not just about talking about drugs they're on now, but also about asking about medications they may have been on in the past that might have left them with scarring in the lungs. The same holds for the next category, which is exposures. So we need to ask about environmental exposures that they might be breathing in, causing damage to the lungs. These can be occupational exposures. So for example, if someone was involved in the installation or removal of asbestos, they can get an interstitial lung disease called asbestosis. And that might have been something that they did many years or even decades before. So we need to ask about all the jobs a patient has ever had in their life, not just the job they have right now. We also ask about organic materials that they may be, I mentioned inorganic materials that they may be exposed to. But we also ask about organic exposures. So these are things in the environment that have an organic base. Some patients breathe these things in and they're fine, but others will breathe these things in and develop interstitial lung disease. So we ask about specific exposures to pets, feathers, feather pillows, mold in the bathroom or the basement. Even someone who has freestanding water in a jacuzzi that they use every day might be breathing in some organisms that are growing in that water that can cause lung diseases. Finally, we ask everybody with interstitial lung disease about risk factors that are outside of the exposures. So we ask about smoking and genetic history of either connective tissue disease or interstitial lung disease. As an example, if you come to me with an interstitial disease and you have a sister who had rheumatoid arthritis, that might make me think a little bit more about whether or not your lung disease could be due to a connective tissue disease. And that's why it's important to ask. Once we've taken a careful history, we move on to the physical exam. The physical exam for someone with interstitial lung disease includes a respiratory exam, where we do the usual things of inspection, looking for accessory muscle use and cyanosis. We look for clubbing, which can be seen in many interstitial diseases. We look for muscle weakness and diaphragmatic excursion, and we auscultate the lungs to look for fine inspiratory crackles. We then do a cardiac exam looking for complications of interstitial lung disease. In particular, we're looking for pulmonary hypertension and its sequelae, right-sided heart failure and cor pulmonale. And then finally, in the interstitial lung diseases, it is very important that we do a detailed rheumatologic physical exam, because some patients may not even know that they have an underlying rheumatologic condition, and we may discover it when we're examining them, and that ties together why they have lung disease and possibly some findings in their joints. So we have to look for active joints, we look for skin rashes, and even subtle clues like changes in the beds of the fingernails, and changes along the arms and in the hands. Next, we go on to investigations. Every patient who comes to your clinic who may have a restrictive lung disease should have certain tests done. Patients should have pulmonary function testing, where we look for lung volumes. But not just lung volumes, as we've talked about. You would do volumes, spirometry, and a diffusion capacity, which is essential to help us distinguish between parenchymal lung restriction and extraparenchymal lung restriction. In patients who have extraparenchymal lung restriction, you would also consider doing tests of respiratory muscle strength, like MIPS and MEPS, and positional vital capacity maneuvers. And again, we'll talk more about this in the lecture. Patients would then go on to do a chest x-ray to look for nodules, reticulation, or both. And we should look at the distribution of those changes to see if they're upper lobe or lower lobe to help us develop a differential diagnosis for that patient. A CT scan can often give much more information, and different radiographic patterns can suggest specific causes of the interstitial lung disease. That will not be covered in today's talk or in my in-person lecture, but you'll get a chance to work through that with some of the cases where you'll see CAT scan results from your patients and work through how that affects our differential diagnosis. Next, we go on to do blood work. All patients should have their blood checked for antibodies that are seen in some connective tissue diseases or rheumatologic diseases. Particularly, patients should have a test called an ANA, or an anti-nuclear antibody test. They should also have a rheumatoid factor checked. And there are other antibodies that can also be checked at the discretion of the physician. For some exposures, particularly organic exposures, which cause an interstitial disease called hypersensitivity pneumonitis, in those patients we might do what's called precipitating antibodies. And this looks for antibodies in the blood that are directed towards organic things like birds or molds. We can also do tests like a serum calcium level and an ECG if we suspect a disease like sarcoidosis. Diseases like sarcoidosis can affect the heart and calcium metabolism. If you've done all the tests above and you still are not sure what's causing the lung disease, then you may go on to do a lung biopsy where you can get a pathologic sample. And that can help to know exactly what the diagnosis is if your other tests do not give you an answer. When we talk about treatment of interstitial lung disease, really a lot of what we do is the treatments that we give all chronic lung diseases. So if you go around my circle here, you'll see smoking cessation, rehabilitation, treatment of depression, making sure patients get vaccines, treatment with supplemental oxygen, if required, symptom control, lung transplant in a minority of patients, and consideration of clinical trials to see if they can get access to experimental therapies that may not yet be approved. And these treatments really apply to all patients with chronic lung disease. But there are some disease-specific treatments. We'll expand a little bit more about this in our lecture, but for diseases that are caused by organic or inorganic agents, we should avoid the exposure that's causing the lung disease. So as an example, in a condition called hypersensitivity pneumonitis, patients are reacting to some sort of organic compound in the environment, whether that's feathers, pets, mold, something like that. And so if we know there's an exposure in the environment causing their lung disease, they should obviously avoid that. For inorganic exposures, like silicosis, which happens in coal miners, and asbestosis, which happens in people who install and remove asbestos, again, not only would we try and avoid the exposure, but sometimes we can also ensure that people are using protective equipment so that they can minimize their exposure. In diseases where there's a systemic component, so particularly this group of what we call connective tissue diseases, rheumatologic conditions, or the other name for them is collagen vascular diseases. In these patients, not only do we have to treat the lung manifestations, but we also have to think of what we call extraparenchymal manifestations, so the symptoms and conditions that come with those diseases that happen outside of the lungs. Classic examples include sarcoidosis, where people can get inflammation all over the body, affecting any organ system, or things like rheumatoid arthritis or scleroderma, where patients can have problems all over the body, but specifically commonly with the skin and joints. In these conditions, we might consider using immunosuppression. In particular, drugs like prednisone, which is a potent immunosuppressive medicine, can be very helpful to many types of interstitial lung disease. However, prednisone has lots of side effects and needs to be used with caution. In particular, in the world of interstitial lung diseases, there's one specific disease called IPF, or idiopathic pulmonary fibrosis. And it's really essential that we all know that prednisone has been shown to be harmful in that condition. So whereas you may use prednisone in lots of different kinds of interstitial lung diseases, prednisone should be avoided in patients who have idiopathic pulmonary fibrosis because it is thought to be harmful in that particular condition. We can also consider using a newer class of drugs called antifibrotic drugs. And these are medicines that are specifically designed to stop the laying down of fibrosis or scar tissue. At the moment, those drugs are approved for treating idiopathic pulmonary fibrosis, or IPF, and are not yet approved for any other conditions. So now that we've come to the end of this module, by now you should be able to understand the physiology of restrictive lung diseases, appreciate some of the testing methods used to assess restrictive lung disease, particularly knowing how to interpret pulmonary function testing, and what to look for on chest x-rays. And then finally, we work together to generate an appropriate history and physical exam in a patient who presents with restrictive lung diseases. Thank you very much.